Hi, this is Yolanda Gilder in the show Marshburn presenting today for a patient I reported to the clinic with various symptoms. Patient complaint, chief complaint said, I have recently been feeling down and fatigued. I've experienced unexplained weight loss, pain in my joints, and a rash on my face. And I woke up this morning with blood in my right eye. Subjective, HPI, it's a 32-year-old African American that presents to the office with complaint of fatigue and feeling down for approximately 6 months. She reports a 10-pound unexplained weight loss over the last 3 months. She also noticed a rash on her cheeks and the bridge of her nose about 2 weeks ago. She says it's mostly aggravated when she goes outside near the sunlight. She has joint pain by lateral hands for the past 2 months. She describes the pain as intermittent, aching, isolated specifically to her hands. Joint stiffness is lasting about an hour after she awakes. The pain, she rated it as a 5 out of 1 out of 10 on the scale. For control of her pain, she's been using over-the-counter ibuprofen, and she says it helps to some degree. She also states she woke up this morning with blood in her right eye. The patient denies any injury to her eye, any eye pain or discharge, and she denies taking any type of anticoagulation therapy. Past medical history is positive for gallstones. She has no known allergies, and her current medications consist of ibuprofen, which she's taking 2 tabs every 6 hours as she needs it for the pain and joint pain. She's also on birth control, low estrogen, 24-iron, 1 tab pill daily. Surgical history, she's had a lap chole in 2012. She's up to date on her immunizations with the flu vaccine that was noted in October of 2016. And she's also current with her OBGYN. She's Gravel 1, Para 1. Family history, her mother is positive for rheumatoid arthritis. She has a sister that has type 1 diabetes. Social history, she's currently a smoker, about a half a pack of cigarettes per day. She drinks a glass of wine occasionally and denies any illicit drug use. She is married and has 1 8-year-old son. Review of systems. Generally, she's feeling fatigued. She has an unexplained 10-pound weight loss over the past 3 months. However, she does deny any fever or any other issues. As far as the eye, she has blood in her right eye. No other significant issues there. Next, she denies any swollen glands in her skin. The only thing that's noted is the rash on her face. She complains of musculoskeletal. She has aching joints, specifically in her hands. Neuro, she denies headaches. And psych, she's feeling a little bit down, uninterested in activities. Objective data, blood pressure is 118 over 72, pulse is 80, respiration 16, temp of 98.6. Patient is 5 foot 6 feet tall. She's 140 pounds with a BMI of 23.3. Generally, over review, she's awake, alert, and oriented times 4. She appears to be well nourished, and there's no acute distress noted. Physical examination, her right eye has some conjunctival ecchymosis. There's no visual disturbances. Multiple small red ulcers are present in her mouth. Neck, there's no lymphopathy. Integumentary, there's a male rash on her cheeks and nose. Heart-wise, that's 1 and 2 are normal, regular rate and rhythm. There's no murmur or gout or rub. Lungs, she's clear to auscultation, normal and symmetrical expansion. Abdomen displays no tenderness. There's nothing upon palpation or inspection. Musculoskeletal, she does have red swollen joints present in bilateral wrist and bilateral second to fifth digit. Psych, she has a flat affect. She denies suicidal ideation or plan to harm herself. Diagnostics and lab tests is a urinary pregnancy test while here in the office, and it was negative. It was confirmed to be negative. Her assessment, differential diagnosis and analysis using the systemic lupus erythematosus. Definition, basically, it's an autoimmune disorder of the connective tissue. It's characterized by antibodies that target different antigens. It may affect multiple organs such as lungs, kidneys, and cardiovascular system. The etiology is unspecified. It's basically linked to genetic predisposition, immune dysfunctions, and environmental factors. The pathways of complex interactions of immune dysfunctions, genetic predispositions, and environmental factors. Risk factors, though, however, noted here for our SLE is smoking, African American women of childbearing years, anyone taking oral contraceptives, specifically African American women, hormone replacement therapy, celiac disease, occupational exposure to silica or mercury or agricultural pesticides. Prevalence of SLE is common in African American women of childbearing years, 25 and up. Common symptoms consist of a malar rash, fatigue, weight loss, depression, symmetrical polyarthralia, and non-deforming arthritis, oral ulcers, ceratosis, leukopenia, and immune thrombocytopenia, and also hemolytic anemia. Sojourner syndrome is the second differential diagnosis that we also reviewed. It's also an autoimmune disorder of the connective tissue characterized by exocrine gland dysfunction and dryness of the mucosal surfaces. Etiology here is unspecified, but it's also linked to genetic predisposition, immune dysfunctions, and environmental factors. The pathophysiology of sojourners is basically an autoimmune reaction, which is triggered by environmental stimulus and expression of epitheliitis. Risk factors consist of genetic, specifically a first-degree relative with SLE, exposure to cytotrophic viruses are women greater than men. All ages, but it's greatest among women 30 to 50 years old of all ethnic groups. Prevalence is the second most common autoimmune rheumatic disorder. It affects 1 to 2 million citizens, and it's more prevalent in women greater than men. Common symptoms of sojourners consist of fatigue, parotidic swelling, low-grade fever, xerostoma, submandibular swelling, vasculitis, and polyarthrasia. So the joint pain is also here. Assessment, another one that we found for differential diagnosis was your idiopathic thrombocytopenic purpura. It's an autoimmune disorder characterized by immune-mediated destruction of the normal platelet. Etiology here is unknown in the primary ITP, but secondary ITP can actually occur due to autoimmune disorders such as SLE or Evans syndrome. Pathophysiology, antibiotics bind to circulating platelets and mediate clearance of platelets by tissue macrophage. They do this by forming surface fragment and crystallization receptors. Risk factors here is going to be someone with HIV infection, hepatitis C, or Helicobacter pylori. The prevalence of this particular disorder is in women of all ethnic backgrounds, ages 30 to 60 specifically. Common symptoms associated with ITP consist of facial PPI, generalized bruising on upper and lower extremities, the joint pain again, polyarthrasia, and then HSP. The last differential diagnosis and analysis that we completed was rheumatoid arthritis, as the client did state that her mom was positive for rheumatoid arthritis as well. Definition is a systemic or a system inflammatory disorder characterized by symmetrical relapsing destructive psoriasis with multi-system involvement. The etiology initially is going to be inflammatory response, which is basically unknown, but however, it's linked to genetic and environmental factors. The pathophysiology of RA is autoimmune stimulates proliferation of the synovial macrophage. And in return, these joints actually grow something called a pannus tissue, which actually destroys cartilage and bone. Risk factors, again, it's going to be smoking, genetic disposition, specifically first-degree relatives that has SLE or RA, absence of hormone replacement therapy, post-traumatic stress disorder. This particular diagnosis is prevalent it's 3 times higher in women of all ethnic background, ages 30 to 50. Greatest prevalence is women of all ethnic background, ages 65 and greater. Common symptoms here is going to be your morning stiffness, polyarticular development, and arthrasia. Labs and diagnostics that's specific to determining the final diagnosis here is going to be your anti-nuclear antibody test, which this test specifically indicates autoimmune disease is present. It's 97% present with individuals with autoimmune, specifically SLE, sojourners, ITP, and rheumatoid arthritis. The confirming factor of SLE is an autoantibody titer. This is what helps to differentiate SLE from other autoimmune disorders. There's also other testing that we'll be doing, and also finally we're going to do a urinalysis to detect proteinuria and hematuria. This is going to further help to define if the SLE, once confirmed, has identified with other renal involvement as an invasion of SLE. Management plan, we confirmed that our patient is diagnosed with 2 different specific disorders. First diagnosis is going to be systemic lupus erythematosus with an ICD code 10 of M32.9. And the second diagnosis is going to be a subconjunctival hemorrhage with an ICD-10 code of 37.72. Our plan for diagnosis, number 1, we're going to incorporate the patient to start and begin initial therapy with plaquenil, 200 milligrams 1 time POVID for 4 weeks. And we're going to do a visual screening test while she's here and inform her of any changes in her eyes or her sight. She'll need to come back to clinic. We're going to give her prescription to go ahead and get an ANA panel, CBC, CMP, urinalysis, C-reactive protein lipid panel, and then the visual field test here. Definitely going to educate the patient on sunscreen to help protect against skin lesions, annual eye exam, exercise regimen consisting of aerobic activity for a minimum of 30 minutes per day times 4 days per week for at least 12 weeks. and discuss family planning if the patient didn't know that she was on birth control prior to. Think about immunizations as another part of the plan. Number 4 on our plan, patient did receive and is up to date on her flu vaccine. However, we'll need to administer a pneumonia vaccine as well. Smoking cessation is incorporated as well to stop the smoking as this is a risk factor leading to SLE. Cognitive behavioral therapy as a referral, just because of the fatigue and depression and pain. We also want to do a referral to rheumatologists to further assess the disease activity and management. And then, of course, an ophthalmology referral as well to complete ophthalmology exam for visual acuity, dilation exam with the retina and cornea, and then do field testing. Patient will return to clinic in 4 weeks for follow-up or call for any symptoms of vision changes, inability to read, blind spots, or excessive muscle weakness. For diagnosis number 2, our plan here will be vision acuity and field exam. Second step on the plan is to buy or have the patient purchase lubricant, artificial tears, 1 to 2 drops in each eye for irritation. We will advise the patient to wash her hands prior to instilling the eye drops. Do not touch the drop into the eye. Use as needed for irritation or dryness to eye. May use throughout the day. No specific limit of drops is applied here. Just teach the patient this condition is self-limiting and will resolve on its own. Just want to make sure the patient understands that the skin color changes that may occur around her eye as well, so don't be alarmed by it at all. Definitely return to the clinic for any fever, vision changes, or swelling of the affected eye. Health promotion of SLE. Teaching your patients how to live a normal, healthy life with lupus is very important as well. So we want to do some health promotion education. We want to make sure we educate her on how to take her meds daily as scheduled. Do not miss a dose. Relaxation techniques for stress management and avoiding the stressors that we can with at all possible. Eat a healthy, balanced diet, limit sugar and salt intake. Protect your skin with sunscreen when outdoors. Keep follow-up appointments and routine checkups. Exercise at least 60 minutes a day, walking 3 to 5 times weekly. And then low-impact exercise such as walking, swimming, or cycling. Rehabilitation is also included in the health promotion, as this may become an issue for the patient because of joint problems and pain. So physical, occupational, and vocational therapy are also incorporated. Disease prevention, since SLE is pre-genetic or genetic in predisposition. Stop smoking is one of the issues that may be a risk factor or is a risk factor. But we want to teach them to monitor for signs and symptoms such as fatigue, painful swollen joints, problems with sleep, skin rash, and general lack of pain. There is no way to prevent lupus since it is genetic, so it's inherited. So we want to definitely teach them the signs and symptoms. Family health model for African Americans specifically, we're going to look at 2 different structures. We're going to look at functional and structural. African American strategies to function with lupus. We want to teach them coping, to discuss the family, the disease, and what steps to help manage them. Understanding, allowing them to ask our questions, get a basis for what lupus is and how it affects their body and how it may affect their family. Compliance, the main thing that many people do is that they forget to continue follow-up maintenance. It's very important that we teach them to maintain scheduled appointments, take their meds as ordered, and follow up for regular checkup. And then acceptance. It's not uncommon for you to have a disease process and not be willing to accept the fact that it's actually there and it's prevalent. So you want to teach them how to embrace the disease by understanding it and managing the symptoms. And then maintenance, continue all follow-up appointments and medical screening. Structurally, we want to make sure that this patient incorporates her husband and her son into the plan of care for her and to deal with her routine or her disease disorder. So we want to create a healthy diet chart. We want to teach her how to limit high-fat foods and increase fresh fruits and vegetables. How to seek local medical assistance once the medical plan and treating has been completed. This patient is more likely to seek help if it's closely available. Stop smoking and avoid others who smoke, so this may curb her appetite to want to smoke. Practice good hand hygiene, washing hands, sanitation, practice overall good hygiene, avoid those that may have some kind of respiratory infection or sinus congestion. You want to avoid all injuries or illness at all possible. Of course, incorporate family with exercise routine, play outdoors with sunscreen, and include family disease management. This is a tree of what we can teach them as well. First, we start with the mind-body connection, how to cope with the lupus, and then the tree stems off and it incorporates the good eating, exercise, and incorporating family time in there. And on the other end of it, it also actually incorporates how to relieve stress, how to make sure you follow up with your disease maintenance. Keep family routine, incorporate family meal prep, discuss your complications or your disease process with your family. Avoid illness and injury, communicate, and live a normal life. Return to work, maintain socialism, and incorporate rest if needed because of aching joints and pain. Last but certainly not least, live, love, and laugh each day. Lupus is made to have a normal life. With proper disease management and proper maintenance, you can live a normal functioning life. Incorporating community resources, there's a lot of evidence and help out there for someone with lupus. American College of Rheumatology and Lupus is one site that you can get information and tips and guides, Lupus Foundation of America, and then your local health unit in your community. These are our scripts for our patients to receive our blood work and any other medical treatment. Thank you for the presentation.